livestock. For some, the fear of the weapon of mass destruction, and in reality, we are faced with one. However, one thing that has been said, that has been established, is that in the face of biosecurity threats, the environment, the economic sector, the health sector are usually the areas that are adversely affected. These are just some images to describe the physical qualities of biosecurity threats. This is usually the things we see in the case of emergencies. Concerned with the increased risk of morbidity or arrested hemorrhages and including the fractures. We saw how all attention was pushed to the physical health sector. And there was disruption in the health service. There was some confusion at the beginning of the pandemic across the world. Yes, in the socio-economic sector too, it has impacted our lives. We had several presentations with that regard and the way forward. There are losses, property, jobs, and the support system, not just from the direct consequences of the COVID-19, but we have seen the ripple effect of the lockdown and the video noise and urbanization. So the ripple effect has also impacted on our socio-economic sector, the prevention of physical amenities and food shortage. So usually, in the face of all the security threats, we see that we focus on the physical aspect of health. This picture captures some parts of Eastern Africa and the whole of Africa. You can see desert focus, ravaging crops. What hits you when you see this picture is, oh, this farmer has going to lose a lot of crops, this is going to lose money and all that, and maybe the government has to disappear. But for us inside the mental health sector, what we see is a man who is faced with several life challenges because all the money had borrowed money to invest into the farm, and now his crops have been destroyed. There's a possibility that the debtors will come calling, and then he's going to have his first nights. And then he begins to feel sad, he feels what's life. But he wants to share it with people, and he said, please, man, it's one of those things, it's happened to everybody. But we forget that this person has different life experiences. This person has his own personalities and challenges. And because he cannot see an outlet to address these issues, he's contemplating suicide. But we don't see that part. What we see is usually the physical aspects. We view it in the telescope of the physical components of health. For too long, mental health has been the topic. For too long, we have looked at public health emergencies through physical and to some extent social. And at this point, I'm reminded of the tricycle. Yes, the tricycle might not be as fast as some two-wheel, some four-wheel vehicles. But one sure thing is that it will definitely get you to your destination. For peradventure, one of the wheels gets punctured, one of the wheels gets twisted. Unlike when we have a flat and we have to use that funny shaped wheel, we can only go so fast and so far. Because the truth is we are weak as we are strong as our weakest link. But somehow we have a regulating mental health to the rear. And I think the important at this point was to look at, remind ourselves of the definition of health. I have highlighted the components: physical, the mental, and social. It's a tripod. And I like when the MC used the illustration of the tripod poles. It can only function when three legs are there. Some people said we should look at it from an aspect of four-component, four-dimension definition, including the spiritual, because research has clearly shown that patients or people who believe in an entity greater than themselves actually do have the best capacity. But we're not asking for too much. Just give us the physical, the mental, and the social. So I want to ask, or I want us to just ponder, why is there the effect? Why is it that mental health is not usually carried along? Well, we are thankful during the COVID-19 response. At some point, we were remembered after 3 months of the establishment of the PTF task force. So we are grateful. Yes, we may not remember initially psychosocial response there is no link between biosecurity threats and mental health. Or is it that one of mental health is minuscule and it's not relevant? I'm not going to go on to this slide because we've had so much presentation of biosecurity threats across the world, biosecurity threats in Africa. I'm not going to pause, but I just want to remind us of the fact that, yes, we do have biosecurity threats, they are here with us, and we have seen theories, research that support the link between mental health and infectious disease. It's not often news that at the initial phase of COVID-19, when the pandemic was in the initial phase, it was thought to be majorly respiratory disease, but we have seen that it's multi-systemic, and it actually has some link with the brain. So neurotropic properties, we are seeing some ways that it can get into the brain, causing blood-brain barrier, causing the immune system to overdrive and getting infection, a lot of inflammatory response, and also blood-causing abnormalities. So are there common mental health conditions that linked with biosecurity threats? Yes. There are myriad of them. But the common ones that we have seen repeatedly, not just COVID-19, but with a series of infectious diseases that we have faced with Ebola, Lassa fever, we see anxiety. We cast the mind to when there was a fear of Ebola outbreak in Nigeria. There was panic, we had hysteria. People were drinking salt, doing all sorts because they want to come down with the disease. So it's we don't need research to know. However, research is very important. So there's anxiety, there's PTSD, there's depression, and we're seeing a lot of people using substance use, alcohol as another active coping mechanism to escape from their fears. With increasing population being exposed to biosecurity threats, it's not surprising. And then you want to ask, are there particular occupations that are faced with biosecurity threats? Yes. Studies have shown the farmers, because when the environment is affected, farmer is one occupation that the farmers are one group of people that are affected adversely. And studies have also shown that their suicide is quite high with them. Frontline workers too, at higher risk of mental health problems. We have some research which have come up. I and a few of my colleagues have done some research, and we saw that 22% of depression was found to include some of the couples during the lockdown had some form of depression following the COVID-19, and several others are coming. But what we see is that preparedness is poor, particularly when we talk about incorporating the mental health sector. So at this point, we now want to look at the burden of mental health conditions. Maybe it's not subtle, maybe it's not something that is major, that's why it's being neglected. But as of 2015, the mental neurological consultancies, that is mental health conditions, contributed 40% of the global burden of health, or disease rather. That was 5 years ago, before the turmoil, before the pandemic. It had a significant proportion of the global burden of disease was contributed, mental illness contributed that aspect. And interestingly, 75% of people with these conditions are in sub-Saharan Africa, in low and middle income countries like Nigeria. As of 2016, 4 years ago, 1 billion people suffered from mental health problems across the world. Now the population of the world is 1.8. So we are saying that at least 1/7 of the world's population have a form of mental health challenge. However, I know that not is manageable because with the increasing turmoil, we are seeing an escalation in mental health conditions. And it goes on and on, and it goes on and on. So coming down to Africa, are we exempted? No, on the contrary, it's even worse in Africa. Because in Africa, we have a wide treatment gap. That's the number of people who are exposed, number of people who have mental health challenge, and as against the number of people who access treatment. In Nigeria, it's just 20% of people who have a mental health condition that actually have access to health care. It's worse in countries like Syria, that's over 90%. Actually, as 2018 was 98.8, and 85 in Ghana. Our health workers, we have a problem with health workers, mental health workers across to 100,000. However, in certain European countries, it's up to 50 to 100,000. In Nigeria, we'll come to Nigeria anyhow. Are we being funded? No, we're not. Less than 1% of the health budget goes to mental health. And when you look at the expenditure per capita, it's actually non-existent. So we're just getting the crumbs of what comes from health to push forward. But wait for it, because the pandemic is running. It's not one of the news. And mental health it's going to be the pandemic in the aftermath of everybody correctly. In Nigeria, okay, this is just a study support the fact that if we stop being reactionary, we like see what was our place to be, we'll realize that we engage in preventive measures will actually save us a whole lot of stress, return on investment, and benefit the health and economic sector in Africa. This is a map just describing what I mentioned about number of psychiatrists per 100,000. And the brown, the part of the wall that is in brown, the brown is colored brown, that's majorly what you see in Africa. 0 to 1 psychiatrist to 100,000. Actually, Nigeria is not up to about 2 to 200,000 people, which is pretty worrisome. As at 2019, the federal government released a report and said 26% of Nigerians have one form of mental health challenge. Break that down, that's 40 to 60 million people. During the course of the COVID pandemic, about 2 months or so ago, the president of the Association of Psychiatrists in Nigeria reported that it had gone up to 40%, that's 80 million people, and it's still climbing. Because we're having more people coming out with mental health challenge. But okay, so I have to watch your time. I don't know how I just overshoot. I think I was not to. So yeah. So sorry, I lost my stream of thoughts. Yeah, we're having less psychiatrists addressing mental health challenges, and we have an ongoing break going on. So I thought that the negative is pervasive. It's across board. It's across board. Despite all that we're seeing in the global health security agenda, it was excluded in the 8th action package. Global Preparedness Monitoring Board, the WHO, its first annual report, they also excluded mental health. The global health security is the same thing, even in the Millennium Development Goals, it's not like it was excluded. But with a lot of hue and cry, it was included into the Sustainable Development Goals. And the truth is, you cannot push mental health without, you can't push all these goals without incorporating mental health. Can I ask for 5 minutes, please, the CEO, please? I'm a bit out there, sort of like that. Thank you. Permission. So this is the 3 monkeys, label, here label, that's the story of mental health. We know it's there, but we don't want to see. We know it's there, we don't want to talk about it. We know it's there, we don't want to hear about it. And stigma, it's not what that means that stigma is the contributing factor. Oh, I don't want to be told, it's easy for you to, somebody has diabetes, you send a blood loss to the car. Somebody has hypertension, like but somebody comes down with mental health condition and you highlight his name for retrenchment when you have to downsize. It's alien to our culture, no, it's not alien to our culture. When we look at suicide, one of them, mental health really causes suicide in our society. You know that when we remember Shango, the god of thunder, and committed suicide, I'm not saying that mental health. When you look at things fall apart, or what died from suicide. So it's not related to our culture, but there's a more awareness, and that's why someone like me, I'm here now in the Biosecurity conference talking about mental health problems. Our policy is favorable? No, we don't have a mental health law in Nigeria. We still operate on the Budeski Act of 1958, inherited from our colonial masters. So how does this relate to residents? you might not, no, take back to the slide. How much residents have somebody who lacks mental capacity carry out? Somebody who lacks mental capacity handling the Biobank, handling a very sensitive position in the Biobank, can access sensitive information. And then you see how terrorism is happening. You see Biobank is happening because you can use the virus pathogens, the virus pathogen to do havoc. If you remember the anthrax attack in 2001 rather, we saw that you can do anything, but it's important that we ensure that people who are mentally stable are the ones that handle such positions. A farmer who has been considered at least depressed, how much residents of that person want to, how much residents can see that person? You can't be bothered. Whether your discourse is strong or not, you can't be bothered. Someone who's already paranoid, and then I'm listening to this conspiracy theory, and you tell them to come and take vaccination, you're wasting your time. So it's important that we need mental health and residents. Yes, we see the definition, it's no longer in use, but is it functional? We need definitions that capture it along the system, along individuals, along structures, from the individuals up to the highest level of government. And when we look at residents, we don't just look at it in isolation, look at it along the continuum of life. We can't be talking about resilience, the same method of approach for an individual here on the BI, and that who is in that market, it doesn't work. It's not the one size fits all. You have to be flexible. Or when COVID-19 lockdown happened and we were worried about schooling and all that, people in the academy can just try to stay. I've been out of school for like 6 years. So you have to ensure that the strategies that you employ is flexible and it's personalized. So I want to bring remind us of the definition of mental health. I'll also be rounding up, please. Definition of mental health. Because the same factors that support residents are the same factors that promote mental health. So this is what mental health means. But if a proportion of the population lack the ability to realize their potentials, lack the ability to cope with stress, lack the ability to contribute to their community, how the resident can help society? There's the original relationship. So what way forward? There has to be a paradigm shift. It's about time we begin to engage multiple stakeholders, inclusive, coordinated, and integrated approach. And that's why I will thank the leadership for pioneering this. I wouldn't, because of our time, I'll skip this and go to local strategies. We need to begin to, take it back. Advocacy. That's why I'm here. Let us know that we can't be talking about security, we can't be talking about strengthening Africa's residents in tackling emerging threats, our security threats, if we are not capturing help in totality. So we need to engage in a policy program. We already did that on mental health front, but it has to be an inclusive thing now, multi-sectorial. Ensuring development, mental health security, going into the communities, not just staying here in our comfort zone, in Lagos, I'm talking about, but going to the communities, I'm talking about taking a multidisciplinary team with us. And then utilizing local and cultural sensitive interventions. Yes, the get should look into having tools, not just a standalone thing, but loving tools. I like the fact that the previous speaker put out the joint evaluation, internal evaluation sheet, because mental health and experience, so together can take the lead and have one incorporate mental health. Research is very vital. If we look at it, we'll see Africa is not on the radar here. Africa is not on the radar, but we have what it takes to write our own school. We should stop waiting for people to write our school and then we'll complete the goal. We should begin to do research. Turn it around. Because we can't ask for money, we can't ask for funds. Yes, cash has been said a lot of times. But how do you defend the cash when you cannot show the magnitude of the body? But we need research to do this. Yeah? International strategies, more cooperation, more collaborative, approaches, yeah. Yes, it's no longer used that COVID-19 ensured physical and emotional isolation, insecurity, and stigma on individuals globally. The magnitude across sectors is still recovering from it, and it's no longer used to that. In the aftermath or currently, we are going to be seeing a global mental health pandemic. What's important is that we should learn from the lessons. We have several opportunities to have learned, or we have been waiting for people to write us. It has to change. Going forward, conferences like this should change the narrative. Integrating holistic approaches, facilitating, yeah. Then, like I said, research and the use of technology. We've seen it being played out there. We have physical presenters, we have virtual presenters, use of technology. At some point, earlier this year, I talked about giving regular treatment, regular services, mental health services via Zoom that we consider somewhat of mental health to some people, but we're using it now. So we should encourage the use of that. So in conclusion, thank you for giving me time to conclude. Yeah, in conclusion, I will say, use the words of Patel, one of our renowned psychiatrists, there is no health without mental health. For too long, mental health has been sidelined despite the enormous burden of diseases. And the solution for mental health from our security initiatives is to encourage our fragile health sector and persist the lack of evidence for present and future health crisis. Our God contains with this Chinese program. The best time to plant a tree was 20 years ago. The next time is now. Thank you.
Now with them is that they are relatively speaking huge, ranging in size from few millimeters to inches and more than that. Well, therefore, our picture, PharmaSeq picture, is attractive in terms of tagging, authentication in biomedical research. Well, if we have a picture, we have to have a reading device to read IDs of the picture, and that's a picture in the high-level schematic of the reader. It is a wand type of device, length about 12 centimeters. And the key element of the reader is the laser. So that laser shines light on the picture, radio frequency signal comes back, and electronics inside the wand processes the signal and sends it to the laptop or a tablet. Well, the picture works so well for tagging and also in bioassays because it tolerates adverse conditions quite well. It is stable to temperature changes. We can go from minus 200 degrees Celsius, that's nitrogen storage in biorepositories, to 500 degrees Celsius. Amazingly, at minus 200 degrees Celsius, the picture ID will read fine. Well, picture is stable to microwave radiation, high G-force, also solvents and reagents like those typically used for staining in histopathology. The picture ID can be read through animal tissue. That's why the picture is perhaps the best tag for tagging laboratory mice and widely used. I'm going to focus on pictures in biorepositories. We developed several types of readers other than what I showed you earlier, the one. Here on the right, top right, we have a single vial reader. In a device like this, we will place the tube in the opening on the top, and with no delay, the ID will be presented on your computer. If we want to read glass slides in tissue cassettes, we would slide them through the opening in another type of reader. And finally, we have a reader for racks of tubes. You may ask, how do we tag test tubes, vials with P-chips? We have at least a couple of methods to do so. One relies on placing the P-chip in a cavity in a specially designed tube, covering this with a lid and a heat staking, and that way we get tubes which then appear like this. The P-chip is the thing on the center bottom of the tube, and a rack of P-chip targeted test tubes. Another method to place P-chips in test tubes is to heat staking, a thermal embedding method. And I got a couple of movie clips. This is the first one. We call it the array reader for racks of test tubes. I'm going to play the movie clip a couple of seconds, and you will see how we read P-chip IDs. And that was it. Very easy indeed. Okay. Well, it turns out, amazingly enough, that P-chips do not have to be embedded in plastic of the test tube to provide tagging for patient samples. We have a collaboration with a lab directed by Dr. William Grover from the University of California, Riverside. And they are working with us to show that the tagging method in which the P-chip is simply placed inside the test tube is adequate for sample tracking. The advantage is that when we want to move the sample, the P-chip will travel with the sample. So there is quite a bit of work going on in this field. We have a grant from the Bill and Melinda Gates Foundation, Phase 1. We applied for Phase 2 of that grant, and we'll see how it goes. But I want to mention one thing. We have a very significant collaboration on this project with the institution that you will know very well. The name is ILEAD, which stands for African Laboratory. That's an African Laboratory Initiative named Innovation in Laboratory Engineered Accelerated Diagnostics. They have 3 centers of excellence in South Africa, Mozambique, and Senegal. Well, a frequent problem in the histopathology labs. Many of you probably know how this type of an image where we have a drawer in a cabinet full of glass slides, microscopic glass slides stacked vertically. It is very difficult to find the slide in such a setting. So we have a solution for that. We have a solution in which we place the P-chip on a glass slide, and you wouldn't guess what the favorite position is. The favorite position for the P-chip is on the sharp edge of the microscope glass slide, as shown in the top panel here. So these are P-chips. You can place them into a cavity on that sharp edge like this. So what it allows us to do is to have a situation where in a drawer with vertically aligned glass slides, the P-chips are exposed, and play this a bit, you'll see how the feature IDs are read, 70 in this case at a time. And if you listen, you will recognize a different sounding beep that indicates that this feature was found by the reader. That sound corresponds to the slide which we are looking for in this particular experiment. That was the sound. Potential benefits in biobanking are large. Improved efficiency, increased accuracy, safety, through improved safety through a reduction of clinical errors, ease of storage and access, and the cost savings. I'm going to switch here and talk about bioassays that will involve our new instrument that's being developed called Cyclone, and I will speak a little bit about DANG immunoassay. Well, again, this type of picture is familiar to you. The picture describes the frequency of DANG seropositivity in Africa. The message from this picture is that it is expected by expert groups that DANG risk across Africa will grow. And that's why we consider it worthwhile to develop systems and assays that can be used to combat DANG and many other diseases. So first of all, let's imagine an immunoassay. This is an example of an immunoassay detecting an antigen. So to do the assay, we derivatize features with antibodies and then expose the feature to the sample. Antigen from the sample binds to the antibody, and then we follow up with the secondary antibody and place fluorescent moiety of the antibody in some way, like with the secondary antibody. So that's a typical configuration of the assay. On the DNA side, we would take a feature, synthesize an oligo, and then derivatize the sample, DNA from the sample, in such a way that we have fluorescent tag on the DNA. And therefore, when the assay is being conducted, we get fluorescence on the feature. And the biggest advantage, biggest benefit from the feature is that we can pursue multiplex assay in one test tube. So it's somewhat reminiscent of Luminex-based assay, but we have several advantages. Then, how are the features read? So these are fluorescent features, and the ID of the feature indicates what type of target we are trying to detect. Features are passed through a channel in front of the light beam, and what the light beam does is that it induces fluorescence that tells us how much target there is in the sample. And second of all, activates the electronics of the feature, which sends an ID, and that way we get the information about what target feature was exposed. So this works quite well. We have an instrument devoted to this assay called Civic, but I'm not going to talk about this much because I want to focus attention on another type of instrument. If you think that passing ships in a channel is a reasonable way to go, you will agree with me that that passing the pitcher in front of the light beam in a rotational motion is also adequate. Well, we can place the pitchers in a test tube and then rotate the test tube in front of the laser beam, and that way acquire data. This is being done, the assay is done in capillaries like this. They are capillaries test tubes used for real-time PCR, very narrow. You see peaches on the tip of the capillary. So when the peaches in the capillary are rotated in a special equipment, we can expose the peaches to the laser beam and then get fluorescence and the ID of the peach. The instrument is being designed. We have a prototype, an early prototype. This picture shows a CAD model on the right and rendering of the instrument. And I want to focus your attention on the extremely small size of the instrument. We compared it to a Rubik cube, maybe 5 inches, slightly larger, 5 inches, 5 inches by 5 inches, and another element that is needed is either a smartphone or a tablet. And this can be connected in principle to a battery in a car, and under difficult conditions provide equipment for tests. That's under development, and we got funding for this project from Center of Disease Control in the US. That's a primary government organization, the focus of which is protection from diseases. So I would like to summarize what I told you. I presented to you pitch technology that gives rise to 2 major applications. One is improved identification of specimen in laboratory, and second of all, access to low-cost assays and instrumentation, with significant benefits in efficiency, accuracy, reduction of medical errors, storage, and access and cost savings. That's the presentation. I want to thank you for attention.
The mission was Lagos State. It's a retrospective project, just like I've said. We use classification, NCDC classification for COVID-19. We are aware there's a WHO classification that classifies patients into mild, moderate, severe, and critical. But we used the one by NCDC that classifies patients into mild and severe because of some of the variables we have and fit into that. The risk factors for severe diseases, WHO guidelines says that those who are aged above 60 and those that have some non-chronic disease like hypertension, diabetes, cardiac diseases, chronic lung diseases, cardiovascular disease, chronic kidney disease, immunosuppression, cancer, and smoking. Those are statistics that can push patients to having severe form of the disease. These are the statistical tests that was used for the work that we did. We used tests to compare numerical values. Next slide, let's go to what we found as our findings. We admitted the norm. Actually, the study periods between when the pandemic started February 27 to the end of September. That's the period when we collected the data. So in all, we have about 370 patients admitted in all our 15 isolation centers, and out of which about 90.2% tested positive and about 9.6% were negative to PCR test. The average age of those who were negative was they were older, that's 46.8 compared to 41.9 of those who were positive. So there's no gender difference between those who are negative and positive. Next slide. Now, this table shows the general characteristics. These are, we're not trying to see. You should see, for those who present comorbidity, they were more. We have a higher proportion of those who were negative presenting with one or two comorbidity. The risk factors for severe infection is also higher and statistically significant in those who presented or who are COVID negative. Also, the symptoms also. So those who are negative, the COVID negative patients presented with more symptoms. If we look at in terms of disease severity, we find that we have more severe cases among those who were eventually negative. Now, the outcome, that is those who are discharged or that we have more deaths among those who were COVID negative. That means we have more people dying who were actually negative. Next slide. Okay, now in terms of comorbid conditions, we have among more people among those who are negative, we are hypertensive, diabetic, a higher proportion have cardiovascular diseases, a higher proportion of them, a higher proportion have cancer, and also a higher proportion of those who are negative were elderly. Apart from immunosuppression, in which we had a higher proportion having COVID positive. All other comorbid conditions, a higher proportion of those who are negative had this comorbid condition. Next slide. Now, in terms of presentation as well, apart from loss of taste and loss of smell, a higher proportion of those who are COVID negative have fever or breathlessness, weakness, and all other signs and symptoms that is usually peculiar to COVID. Next slide. Now, in conclusion, if you look at this, you can see that there's actually, we have a bit more people having comorbidity and having some of these symptoms that came out COVID negative that were COVID negative. So what that one tells us is that laboratory diagnosis remain key in identifying COVID-19 patients, and also the volume of testing and the turnaround time of laboratory results are crucial in the control of the pandemic. Thank you. Next one. At this one, we're looking at trending mortality, like in terms of mortality, and what are the factors that we get among COVID positive patients. Next slide. So I'll just go straight to the results, no room for formalities. Next slide, please. Mean age of our patient was 41.9, and the age range was between 3 months and 98 years. Next slide, please. The age distribution, you see that we have more people who are between 30 and 39, and let's say between 30 and 49 years. So these are this is the age distribution of patients treated in all the isolation centers. Next slide. And symptomatic patients are about 51.4%. Those with comorbidities they are about 27.8%. And management of hospital stay was longer in patients with no risk factors than those that presented with risk factors. It's longer in those that. Now this is the trend. When we started this response, it sometimes and peaked at last week in between last week in June and May and the first week in June. So the peak was actually in the first week in June. Then thereafter, there was a decline in the number of deaths that were.
1 minute more.
Yeah. Next slide. With mortality, we found out that mortality with advancing age, also males, more the symptoms, the higher the death rate. Next slide. For the males compared to the female, they have about 50% chance more of having mortality among the male than the female. Also, those that presented with both symptoms and comorbid conditions, they have about 2.8 chance of dying, and those that have severe disease have about 15 full chance of dying compared to those that have lung disease. These are not my last slide. Next slide. Alright, when you look at some of those risk factors that we talked about, age, having those who have diabetes, those who have immunosuppression, and those who have cancer, they have higher chance of dying compared to those who don't have some of those comorbid conditions. Last slide.
Thank you, Doctor.
Thank you very much.
Thank you.
Please, next one. We have target genes for some of these things, what we'll do in the lab for PCR. And now, let's look at the problem that we are looking at. Among the commercially available kits that is developed for the diagnosis of SARS-CoV-2, the problem of specificity and sensitivity have repeatedly been a growing concern in detecting the presence or absence of the SARS-CoV-2 and in samples that are sent to the laboratory. And on the next slide, please. So our aim is to investigate and compare the diagnostic performance of these selected kits. Next slide, please. So the normal methods that are done, the kits, availability of the kits in the lab, accessible information. Some of the kits comes in languages that you cannot even read or that was here. Compatibility with different real-time PCR systems, the common detectable genes, and also presence of endogenous internal control, which is very, very important. Next slide. So, the selected commercially available PCR kits that were selected were Danji, Sancho, and then the BGI. Next slide, please. So, please, next one. So, the samples, nasopharyngeal and also Mutiu, were brought to the lab, and these were processed to isolate RNA, which is now then turned for PCR. Next slide. So, all generated CT values were processed using the results, the normal statistical tools for doing the normal thing. Let's go. Next slide, please. Now, let's look at the results. These are the results that were generated from the selected PCR kits. We can see the sensitivity of the first one, Danji, Sancho, and the BGI. Danji has a sensitivity ratio or percentage of 34.69, where Sancho has 89.80 and BGI 40.82%. And the specificity of each of those kits we have for Danji was almost 100. For BB of them were 100. But what's so interesting is the negative predictive value, or the first negative rate, which we have for Danji to be 65.31, Sancho which is 10.2, and also for BGI, which is 59.18. All these results matters a lot in the choice of kits that is going to be used to get a very good result. Next slide, please. And this is the rock graph. We can see for Danji, that's sensitivity against specificity. We can see for sensitivity for Danji, close to 40. For Sancho, more than 80. And also for PGI, we have about almost close to 40. Next slide, please. So this is a combination of the three kits. And then we are looking at, we can see the area under the curve for each of them. Sancho has the highest. That's the red one, from up down. While followed by BGI, the blue, and also Danji for green downward. Next slide, please. So, this is the pairwise comparison of the criteria for each of the kits. And we can see the results of them and the confidence interval for each one of them. Another next one. Okay. In conclusion, after looking at and comparing these three kits, without any conflict of interest of anything, Sancho has proven to be the best kit in performance, both in sensitivity and specificity for SARS-CoV-2 COVID-19. Although the other two kits are also not doing badly, but Sancho ranked highest among the three of them. Next slide. These are references. Thank you so much.
Thank you very much. public health facilities and one central Kochi, and in FCT, we visited one public health facilities and one private health facility. That's making a total of 5 facilities that were assessed for this study. We used Excel-based templates to collate data from those facilities. The goal was to assess their antimicrobial resistant patterns for common pathogens that were occurring in these 2 states. The purpose of this was to provide data to NCBC towards their antimicrobial supervision program, specifically their some sorts of region, but just to do a picture of what is happening in the country. So, first we evaluated the laboratory units. We looked at using the WHO assessment and criteria. We looked at their equipment, their calibration, the human personnel. We looked across a range of criteria just to assess if these facilities were capable of being included in the network of labs that will be submitting data towards the antimicrobial resistance. So, for the purpose of this study, like I said, we settled on 5 laboratories, 2 in 3 in Lagos and 2 in FCT. And we used Excel-based templates to pull out the records. That's the laboratory records from their labs. The patients normally receive the lab for antimicrobial resistance test, and these records are included in the lab, and those records are included. So we blinded the section for the identifying information, just collected specific data like age, the sensitivity, resistance, target patterns, and all this information, which is what made the basis for this study. Result, what we found. The first upper slide, first upper coverage of the second slide speaks to the demographic profile. That's towards the left-hand side of the table. Speaks towards the demographic profile of people that we I didn't know I was supposed to share this with you. Sorry, I'm going to share this with you. Sorry, I didn't know I just screen with it. Since I sent I just okay. So records were pulled from the records were pulled just for decision of factor variables. We had more of the females coming in. That was 9.3% of females coming in with issues. However, this data was at 32%. Like I said earlier on, the profile of facilities that were assessed, we had 68.5% of which were public facilities. The clinical samples that we looked at were more of samples collected by mainstream urine, which made 25.2%, and this was sputum. The age category, we have more of the adults at 29.6% that presented at the distribution of samples. What we found was that more of, like post-study reports, we have more of sample tutorials that were reported, and out of the total of after culture, we had Klebsiella species, which is made of 40% of negative isolates, most that were most positive from our study. So a breakdown of frequency of bacteria from the specimens collected. We had more of urine samples collected, like 52 samples that included positive isolates. We had of these 52 samples, we had like 35% of them which were certificates, and we had vaginal swab collected. We have more of polyphone species which were 50%. Something that was a gap that we noticed was that what was in the records, it did not indicate what source of what was the source of specimen, whether it was semen, urine was not indicated, and this made up a major bulk of the isolates that were found. Those that were not indicated stood at 6.9% for starting players. Going on to the distribution of bacterial isolates by gender and location, we have what we found was on Staphylococcus aureus, just a illustration that in females we had Staphylococcus aureus, Vaught, followed by E. coli. By location, we had more of Staphylococcus aureus tests. Sorry? Okay. All right. For the sensitivity, so for the sensitivity aspect of the culture, we found that most of the antibiotics, Staphylococcus aureus was more sensitive to gentamicin compared to the whole gram negative compared to Klebsiella species, which was also most sensitive to gentamicin, followed by overall, what we found was for our discussion, we found that the vaginal pathogens were majorly affected, and pathogens were mostly affected, causing financial implications. Staphylococcus aureus was the leading major cause of infection in blood facilities. And both gender, that's males and females, were equally affected with Staphylococcus aureus, like the similar species. One other thing we found was that the multi-drug resistance pattern found for majority of the pathogens, which the 2% of those isolated bacterial pathogens were found among neuropathogens. We found functional resistance observed among first-line antimicrobials. That includes Chinazole, tetracycline, secondary inflammation, antimicrobials were also affected, including third generation antimicrobials. So these are the maximum resistant profile that we have studied. Staphylococcus aureus was opposed to multi-drug resistant causing across all antibiotics, followed by Klebsiella species. The least resistant or high sensitivity were found with nitric acid and ampicillin. What we have concluded from this study was that there should be there should be increasing more surveillance across prevention and control across antimicrobial resistance patterns across the country, and the works and activities of laboratories should be monitored to ensure that the repeat of sales criteria the minimum have for sensitivity and AMR testing across the country. Because this data fits into national data, it's expected that these markers are the minimum meet their quality test. So there is a need for control. That is my conclusion. Thank you.
Thank you very much, Dr. I'd like to call on Adegoke and Mutiu for presentation, please. Adegoke and Mutiu, I'd like to call to further carry out the investigation, to further detect the causative agents. We find out that there are some point of care tests available which specifically detect IgG/IgM. So to this end, we decided to conduct a study, a prospective observational study, to evaluate the performance of these point of care tests. Next slide. Our aim is to evaluate the performance of 6 point of care tests. And to achieve this, we have to evaluate the next slide. We have to evaluate sensitivity and specificity. And finally, to determine the particular point of care test that meets up with the test of accreditation. Next slide. What problem are we facing that made us decide that we should look for another alternative testing method? Considering the population of Lagos State, which is a mega city, there is need to test more people to actually curb the onward spread of infection. So to this, we need to develop a rapid test protocol to ensure that the desired percentage of our population are tested. Next slide. The methods adopted in our study. 450 participants were enrolled. Their consent were secured, and the consent form were interpreted in our local language. The samples taken for RT-PCR were oropharyngeal swab, nasopharyngeal swab, and sputum specimen, all combined as one for the analysis. For point of care test, that is rapid test kits, we collected capillary whole blood from the fingertip at a different time point after the onset of the disease symptoms. Then the specificity and sensitivity compared with the gold standard were calculated. Statistical data method used were AUC, DOR, positive and negative predictive value, sensitivity, and specificity. Next slide. Hello. From this table, we can see that specificity range from 58.16 to 80.17, while sensitivity ranges from 30.77 to 61.36. This is still not up to standard to say that the test can be used. Then what is striking mostly in this table is false negative results. If you look at the table, you find that
So, so for way of introduction, we could then have the second slide. This is a publication that appeared in Health Security magazine, in the journal Health Security. And what it does, it outlines a global biosecurity dialogue as a model for advancing the global health security agenda. And if I can ask Katherine to speak to it.
Yeah, of course, thank you, Wilmot. Just by a little bit of background, so security leaders often de-emphasize accidental and deliberate biological threats relative to other challenges in peace and security. And given emerging biological risks, including those associated with rapid technological advances and terrorist-specific risks in weapons of mass destruction, biosecurity deserves stronger emphasis in health and security fora. So NTI launched the Global Biosecurity Dialogue to align national and regional donor initiatives towards a common set of measurable targets. The GBD was launched by NTI with support from Global Affairs Canada's Weapons Threat Reduction Program and the Open Philanthropy Project, in coordination with the governments of the Netherlands as the 2018-2019 chair of the Global Health Security Agenda Action Package Prevent 3 on biosecurity and biosafety. The Global Biosecurity Dialogue really provides a multi-sectorial forum for sharing models and enabling new actions to achieve biosecurity-related targets and promoting biosecurity as an integral component of health security. So this paper really dives into how that's been done, the history of the Global Biosecurity Dialogue, and specifically how it's contributed to new national and continent-wide actions, including the African Union and Africa Centers for Disease Control and Prevention's regional initiative to strengthen biosecurity and biosafety in Africa, which we will discuss in more detail later in our presentation.
So thank you, Katherine. So colleagues, this is a heat map of biosecurity and biosafety. And what it wants to illustrate is how under-prioritized it is an issue in the world today. So by way of background to say that, as you know, the joint external evaluations that were done over the last 45 years had questions in the technical areas that dealt with biosafety and biosecurity. And as you know, biosafety is essentially to protect individuals from exposure to dangerous pathogens. Biosecurity is to develop security systems around the pathogens themselves so that they don't get into, so that there's no accidental or deliberate use of the leakage of pathogens. So what the joint external evaluations did in terms of developing assessments is essentially rely on countries to request those evaluations. So this was voluntary. So there was a voluntary exercise to present lots of countries for not assessed. So the Global Health Security Index, in fact, which is released in October of 2019, was an effort to develop assessments for all the countries in the world, so all 195. And this is the result. So it's essentially 2019 data. So it's quite recent and it covers every country in the world, and it's divided into 3 bands, as you can see. So the rest, so in red, countries that are least prepared, in orange, the intermediate level of preparedness, and yellow, most prepared. So you can see most of the world, in fact, is red. And so the entire continent of Africa is red, but together with significant parts of the world elsewhere. So the metrics essentially here refer to biosecurity, to biosafety, but also to what's known as dual sees the global challenge, and the projects that we've undertaken some time to address those. Thanks to you, Katherine.
Wonderful. So looking to this slide, how does the Global Biosecurity Dialogue accelerate new collective and track actions? So first, biosecurity and biosafety are only effective when implemented and coordinated across sectors, such as those that are listed on the slide, so that we're all speaking the same language and working towards common goals. The GB brings together these actors to discuss shared threats. The dialogue also encourages progress according to common milestones, such as those published by the World Health Organization. And the dialogue also really focuses on leveraging expertise and experience from participants to identify barriers that prevent global progress towards biosecurity and biosafety targets, and challenges them to come up with new solutions to overcome these barriers along 3 work streams: policy frameworks, capability development, and emerging biological risks. And I'll give a bit more background on this in a second. And then finally, the dialogue tracks the ideas and commitments that come out of our meetings to hold participants accountable in alignment with existing international initiatives like the Global Health Security Agenda and the Global Partnership Against the Spread of Weapons and Materials of Mass Destruction. And again, we do this by focusing specifically on 3 work streams that were determined during our launch with all of our partners in 2018 in London. And again, they are policy frameworks, capability development, and emerging biological risks. So the biosecurity policy frameworks workstream really seeks to identify urgent actions that enable the implementation of comprehensive national biosecurity policy frameworks as a part of the whole of government biosecurity and biosafety system. And the biosecurity capability development workstream seeks to identify urgent actions that can be taken to build sustainable and multi-sectorial national biosecurity and biosafety systems, including by improving access to regional and international networks of biosecurity experts, to collectively enhance assessments, prioritize and track benchmarks in the national action plans for health security, and facilitate improved political will and resource mobilization. And lastly, the emerging biological risks workstream promotes actions to reduce emerging, future, or unanticipated biological risks associated with advances in technology, improve shared risk perception around countries and regions, incorporate emerging risks into existing tools and plans, and pursue international mechanisms to mitigate identified risks. So, at the Nuclear Threat Initiative, we like to think that we're always working towards systemic change in the fields of improving biosecurity and biosafety globally. So here you can see our model for how we would track this. So we launched the Global Biosecurity Dialogue to hopefully spur commitments to advance regional biosecurity models. Again, we're going to talk about the Africa CDC initiative to strengthen biosecurity and biosafety in a minute. So that was with Mandecki through our Global Biosecurity Dialogue with many partners. And now there's a biosecurity coordinator currently at the Africa CDC who we work very closely with, which is very exciting to see a permanent position there. Step 3, always working towards common metrics. So helping countries, working with countries to work towards set biosecurity benchmarks through their national action plans for health security, and step 4, hopefully at some point achieving systemic change, so seeing improvements in biosecurity scores in GHS index, as Wilmot discussed earlier, and joint external evaluation, and then hopefully seeing this initiative potentially replicated as a regional model, so show the leadership that Africa CDC has really taken on biosecurity and biosafety, and potentially having that model replicated in other regions.
So the initiative was launched on May 8, 2019 in Addis Ababa at the African Union, and the initiative was called, as you can see, an effort to strengthen biosafety and biosecurity on the African continent, which, as you know, and I come from South Africa, Cape Town, is a vast continent of 55 countries. And so we were delighted, in fact, to be able to launch this initiative at the Biosecurity Global Biosecurity Dialogue that was held in Addis with all of our partners. You may be able to recognize some of the faces of the people, but to say that this was an effort that was very closely linked with the strategy that was being developed at the Africa Center for Disease Control led by Dr. Changsha. And as Katherine mentioned, Dr. Talk is now the Biosecurity Officer covering the entire continent and working through the regional collaborative centers of the Africa Center for Disease Control. The Africa CDC, you know the Africa CDC is the youngest and effort on the part of the African Union to upscale preparedness, response, and detection on the African continent. And so we are just absolutely delighted to work with the Africa CDC as a partner. It's a very, very, very good organization, as you know, and has been doing extraordinary work during the COVID-19 pandemic outbreak on the continent. So to say that since we are looking at the Africa CDC as an organization that's both on an architecture of 5 RCCs, we have been holding our workshops with those RCCs as an outcome of this initiative. And we've covered a number of workshops in the meantime prior to the current one that we are busy with in West Africa, starting with the first one in Southern Africa.
Wonderful, thank you, Wilmot. Okay, so Wilmot mentioned that there have been technical workshops that have been hosted by each of the regional collaborating centers. We've now hosted them, each of the regional collaborating centers has hosted them within the Eastern, currently Western, starting with the Southern, and also in Central Africa. 2 of these workshops were in person before the COVID-19 pandemic. Those were in Southern and Central Africa, and then while all of the technical workshops have had 2 of the same objectives, we've added a third due to the pandemic. So I'll just read these. So they are to develop priority actions required to fill biosecurity and biosafety gaps, leveraging national and regional resources and informed by existing health security related assessments, strategic implementation plans to promote measurable progress towards the achievement of the WHO Joint External Evaluations, biosafety and biosecurity targets, and to meet obligations under the Biological Weapons Convention and the United Nations Security Council 1540. And the others to conduct technical working group meetings to provide an overview of risk assessment and risk-based decision-making guides to guide the development of a standardized process to support the establishment of an African Union Biorisk Management Legislative Framework and the drafting of a consensus list of high consequence agents and toxins of concern for African Union member states. But as I mentioned, with the COVID-19 pandemic, the initiative to strengthen biosecurity and biosafety leveraged its diverse community of cross-sectoral biosecurity and biosafety experts to provide much-needed biosecurity and biosafety trainings and to raise awareness on programs specific to COVID-19. So in the Eastern and Western Africa regional technical webinars, there was a focus on both the enduring themes of the initiative intended to fill biosecurity and biosafety gaps, as well as discussion on safe and secure sample transportation, inventory, and storage of SARS-CoV-2 infected materials to prevent accidental or deliberate release of this dangerous agent. So I'll now turn it back over to Wilmot to discuss our first workshop in Southern Africa.
Thank you, Katherine. So the first workshop was held in Johannesburg at the University of Witwatersrand in June of 2019. We assembled representation from all the member states of the Southern Africa Collaborating Center of the Africa CDC. We the key focus of the workshops was to essentially two things, is to work towards developing model legislation that can be lodged at the African CDC headquarters in Addis, and then serve as a resource for both the regional collaborating centers and the resource member states to develop legislation in the area of biosecurity in the individual countries. There's obviously great variation across the continent. Some countries require new legislation, some countries require amendments to legislation, and others require new sets of regulations. So that is the one focus. The other focus was to develop lists of high consequence pathogens and toxins. And so this is the first inaugural training workshop, and it was done in collaboration with the CDC, with Foreign Affairs Canada, and a range of other partners that includes WHO and other agencies, principally as a workshop of the African CDC, looking at member states in the Southern African Regional Collaborative Center. The second workshop was on the one, and Katherine, you want to speak to that?
Sure, if you want. So from October 1st to the 3rd, 2019, Africa CDC hosted the second of the Regional Collaborating Center technical workshops in Libreville, Gabon. So we had participation there from the 9 member states that make up the Central African RCC across human health, animal health, and defense and security sectors. And the 3 outcomes of that meeting were that Africa's Center for Disease Control, Central Africa RCC agreed to set realistic biosecurity and biosafety capacity building goals for the region and track progress. They agreed to request the member states nominate a multi-sectoral body for reporting on successes and challenges in achieving these goals, and apply regional solutions to common challenges and facilitate the sharing of lessons learned in member states. And the Central Africa RCC also pledged to fill recognized biosecurity training gaps by coordinating a regional effort through partnerships with Africa CDC's Institute for Workforce Development, Columbia University, and the Association of Public Health Laboratories to adopt existing biosecurity and biosafety training curricula to the Central African member states. And lastly, for representatives from the Central African member states who participated in the meeting agreed to nominate representatives of the region to participate in the African Union Biorisk Management Legislative Framework Development Process, and sensitize national and regional leadership and technical experts to the framework to enable timely build-in, hopefully once it's endorsed by the African Union. And as Vaught said, these workshops are a collaboration with the African Union, Africa CDC, the United States Center for Disease Control and Prevention, and the U.S. Defense Threat Reduction Agency. And then do you want to talk about the Eastern Africa RCC technical workshop?
So we obviously planned to do this in person, but with COVID-19, it was an effort to offer this workshop virtually, and so it was a real experiment for us to do this. We were delighted to work with the East Africa Regional Collaborating Center of the Africa CDC based in Kenya, and then worked with colleagues there to put this workshop on during this year, June of 2020. So you can see in the picture there, Lennox Kissington from Margaret University in Uganda did the presentation among many others, and in this case, this particular focus had to do with taking of direct action that would look at reducing deliberate and accidental risks during COVID-19 in particular. So that is our current environment, and there are biosecurity aspects to how we need to deal with samples, how samples are stored, how samples are transported, so the whole question of developing biobanks and security systems around that. The question of laboratory security came into focus when it comes to working with with samples and exposure systems and so on. So this was clearly an important time for us to make sure that we upscale biosecurity dimensions to the COVID-19 outbreak. And so what we did is focus in particular on our current pandemic threat and make sure that we use the opportunity to upscale biosecurity systems, certainly on the continent as a whole, but the focus in this case on East Africa. So it was quite successful. The first time we did a virtual one, as this conference here has been held, and as you can imagine, trying to develop a training program virtually in a technical area can be quite a challenge, and we were very pleased with the outcome from our East African workshop.
Absolutely. So currently we're very excited to be hosting with Africa CDC the West African Regional Collaborating Center, as well as WAPO, the West Africa Regional Technical Workshop. So while this workshop is actually still ongoing, over the next few weeks we're going to continue to have track discussions where we're specifically talking about how we can spur collective action under the two main objectives of Africa CDC's initiative to strengthen biosecurity and biosafety, specifically focused on the development of a legislative framework, as has been mentioned, and on capability development. So we're excited to continue to have these dialogues over the next few weeks that are very meaningful to our regional partners in West Africa. And so really to conclude, our next steps are hopefully with the leadership of Africa CDC and the Northern Africa Regional Collaborating Center, we will hopefully be able to host with a host of our other partners a Northern Africa Regional Collaborating Center technical workshop in early 2021. And in order to track the progress that has been made under each of these regional collaborating centers on the issues of biosecurity and biosafety, Africa CDC has put together technical working groups led again by Africa CDC in each of the regional collaborating centers, and we've had the first meeting of the Southern Africa Technical Working Group, which is fantastic. So that will really follow up on all the work that has been done to put together project proposals to move forward to advancing biosecurity and biosafety in each of the regions. And then in early 2021, we're also hoping to host our annual Global Biosecurity Dialogue with a focus on Southeast Asia, actually. So those are all upcoming. At the upcoming GB, absolutely talking about the incredible progress and leadership of Africa CDC and the action that has come truly from the initiative to strengthen biosecurity and biosafety on the continent. So these are our hopefully upcoming events. And we really look forward to continuing to work with Africa CDC on the initiative to strengthen biosecurity and biosafety.
So thanks for the invitation opportunity to address the meeting and to say that our best wishes for what it is you're doing and to salute your leadership in this area of scaling biosecurity and biosafety in the African continent.
Yes, thank you so much to the organizers today. We very much appreciate being able to share with you all this work.
Excellent. Thank you very much. Is that me?
Technology and its potential impact in Africa and elsewhere. But first, a few words of introduction. I am Wlodek and represent PharmaSeq. PharmaSeq is a company located on the east coast of the United States in New Jersey, between New York City and Philadelphia. The company was founded 20 years ago to be a champion of innovative biomedical technologies and more. I am the founder and currently president and director of scientific research at the company. In my spare time, which I do not have really, I am adjunct professor at Rutgers University nearby. Needless to say, technology is key in biomedicine in any country, also in Africa. Why is that? Combating disease, especially fast-changing infectious disease, requires quick response, effective treatments, and diligence when dealing with patients and also patient samples. And this is only possible with new technology when the doctors and nurses can focus on patients because new technology does the rest. PharmaSeq, my company, is active in many areas. Here I will present our contribution to two areas. One involves equipment for biobanking and histopathology, and the other is immunoassay technology, where I will mention our work on dengue immunoassay. It turns out that at PharmaSeq, one technology is common for many types of our developments, especially two developments that I mentioned. This technology is the P-chip technology. PharmaSeq developed an ultra-small electronic chip with memory that is the foundation for both bioassays and tracking and authentication in biobanking. So let's look at the technology. What is the P-chip? Well, this is the tag which in biobanking, for instance, we attach to test tubes and other containers in histopathology to glass slides. That way, after attaching, we give an ID to these objects and can monitor and track them. The main purpose of the P-chip is to transmit a serial number encoded in P-chip's memory to the reader of P-chip IDs. This will happen if the P-chip is activated by light from a laser. So in this picture, we see a P-chip on the lower left where we have a schematic representation of what's on the P-chip. First of all, there is a photocell. The purpose of the photocell is to provide electrical energy to the P-chip by converting light. Secondly, memory. Third, logic, kind of the brain of the P-chip, and also the antenna to transmit the signal to the outside by radio frequency. The size of the P-chip is 500 microns on the side, and the thickness is 100 microns. It's very small. If you are not used to it, it's hard to see that P-chip. The key here is the 64-bit architecture, translating right now to over 10 to the 9th different IDs. We never make two P-chips with the same ID. Also, the important characteristic of the P-chip is that it is virtually impossible to copy its ID, since making the P-chip requires a silicon foundry, a very expensive type of factory, and also proprietary coding. P-chips are made on silicon wafers, top left, where we see an 8-inch wafer containing sections. Each section has 1,000 P-chips, and top right, this is the real image of the P-chip. Let's compare the P-chip with other identification methods in biomedical research. Well, the most well-known is the barcode, introduced in 1974. There is 2D barcode in 1988, and more recently a QR
it has a Facebook page, it has a LinkedIn, and Instagram. Those are the 4 major social media platforms on which he's been interacting. So we are going to be looking at his own Twitter handle, because that is where we have a lot of people interact with him. So social media has played a significant role in mediating communication about COVID-19 from the outset of the pandemic in China. As a tool for communication, it has provided huge information access to Lagos State residents and Nigerians at large during this pandemic. As the COVID-19 became virulent with uncertainty, social media platforms, which are easily accessible on mobile phones, serve as the hub of regular updates. And when we are talking about updates, before we started showing updates, we started preparation in Lagos State. And all these preparation activities were always on his social media handles, from Facebook, Twitter, to Instagram. I should go to the next one. So this is his social media presence. If you look at it, we started with the activation of the EOC, which was well covered in this handle. And we continue to move. As we move from the period of preparation to the period of the first interface, these are some of the sample tweets. We moved from preparation to the ICS, and it was a whole lot of activities, and all these activities continue to go on its handles. Also, after the preparation, we started having some videos made by the Ministry of Health, and those videos went viral. The first of our videos went viral, and it attracted a lot of people from all over the world to that handle. And so we started having a lot of followers. So by the time we had the interface, look at the timeline, we had in December 2019, and by the time we moved to January, I think we had the ICS sometime in ending of 23rd of January, if I'm correct. And that's about a month before we had the index case. So everything was reported, and as it was being reported, people were joining, were following that handle. And by April, we had the highest follower. We had 84,000 followers in the month of April, compared to all the other months that we have started creating awareness. If you look at it, we have community spread versus new followers. Maybe let me just shorten it. Let me go to another. No, sorry. Who removed that? Why did you remove it? Don't go to conclusion, please. Can you give me the monthly one? Please go on.
We have 2 minutes more, please.
Don't worry, go forward, please. Next, there's another one there. This is not it. There is one for the monthly one. It's not there. Okay, let me just speak to it. We have the highest followers for for April, the month of April, and there are many reasons for that. Before April, in February we had the index case, and by February a lot of people wanted more information to know about COVID. A lot of people didn't understand what the COVID is all about. So his handle was that natural place for people to go to get that information, because we have started turning out information about COVID. We have also turned out advisories about COVID on the timeline, and people were looking forward to it. So by the time we were in March, the Alpha case happened, and we published it, and it drew a lot of attention that if one person could test positive for COVID at a very big level, we have a lot of Nollywood people, then it means that this thing is very real. So because we had a lot of people coming in on that timeline. And after that, we also had what I call a spillover, when a lot of people were under lockdown. So they had time to check that handle. After checking that handle, we also had television stations using that handle as a newsmaker during their general news, maybe at around 9 o'clock news or 10 o'clock news. So it continued to attract a lot of people to seek true and genuine information from his handle. And let's go to the conclusion. Can I get to the conclusion slide? So, in summary, the role of social media in COVID-19 Lagos response has been impactful in the management of the pandemic. So, for social media channels have been used to deliver the following: sharing real-time updates, creating awareness through hashtag, prompt dissemination of updates, platform for providing advice and helpline online, and prompt attention to emergency situations. And the leader of the social media team for the Honorable Commissioner is the Honorable Commissioner himself, because he also posts with his hands.
A great and astute control measure. The school, like I said, is located in Ibejulekie, Ojeahere. It's a rural local government in Lagos, but it tends to be a favored site for schools to set up because they're able to get a lot of land there. So a lot of schools that have campuses on the mainland tend to have boarding facilities in areas like Ibejulekie. Total student strength was about 350 and staff 100. Things we noticed there, they had a staggered resumption of students, so they didn't all resume at the same time. They had a standard school clinic with nurses on ground, and they had participated in training by the Ministry of Education, the Department of Educational Quality prior to reopening, which was one of the prerequisites for reopening in Lagos State. And the school also had capacity for virtual learning, both on-site and off-site. Now we use the following case definition. I will not bore us with that. Now, if I describe the index case was a 14-year-old female student, a boarder in year 10. The student had presented with a history of headache exactly 7 days after resuming school. It did not respond to normal antimalarials or analgesics, and parents came to pick her up. She had a COVID test done in a private facility, an accredited facility, and she was found to be positive. We received notification from that facility, and then we swung into action immediately. Methods: we reviewed the clinic registers, conducted case investigation among staff and students. We line listed all the contacts, classifying them into high risk and low risk contacts based on proximity. So those considered to be high risk were her roommates, her classmates, the actor, and though she went to dine, we also got a list of her close friends. We collected samples for PCR testing. It wasn't a very large school, and because it was the first school outbreak, we decided to collect samples from most of the students, particularly after we had a 50% positivity rate in the first set of samples taken. And then we analyzed our data by person, place, and time. Now, our qualitative finding. We said, from our investigation of other cases, this is not the index case now, because we conducted investigations and interviewed every single student on site. And we found out that we actually had a year 12 student who presented with symptoms in keeping with COVID. She had fever, a cough, sore throat. Fever was high grade associated with chills. At the time they resumed, she had those symptoms. And we found out that her sibling was in the same class and in the same room as our index case. So we were suspecting that that could have probably been the primary case to the best of our knowledge. We also found out that several students, a few students had been sent home following presentations with febrile illness, but the healthcare providers had a low index of suspicion for COVID-19. With regards to infection prevention and control, we found out that they had adequate hand washing stations. However, there was poor compliance with mask use among staff and students, and suboptimal social distancing, even within the limits of what they could actually do at the school. Now, when we look at the socio-demographic characteristics, we looked at them by students and by staff. Among the students, 48.4%, 151 were female, and just a little under that were male, while among the staff, 31% were female, while 57% were male. Looking at their locations, for students, on-site means boarding, but they also had staff quarters within the school. So we had, sorry, that's a mistake. So we had actually 78% of them being in school, that's among the students, and 54% of the staff. Now this is the age distribution amongst the students and amongst the staff. Now when we looked at the clinical characteristics, in all, we had a positivity rate of 42.3%. It was 41% among the students and 46% amongst the staff. Now with regards to symptoms, only 27.8% of those that were positive were actually symptomatic. None of the staff reported symptoms. But then the methods of data collection was different. In the students, we interviewed them, but because of time constraints, because of the distance of the school, we actually collected online information from the staff. So this could have actually affected their responses. So we had 39% of the students presenting with symptoms, while 58% were asymptomatic, and we had missing data for about 2.3%. And if we look at the common symptoms, because we wanted to describe this epidemic, we found out that 10% of the students complained of a runny nose. That's the first symptom. Several of them had 2 or 3 symptoms. Runny nose, cough, fever, sore throat, headache, and new loss of smell were the first symptoms that the students presented with. So this is just a description of positive cases by age and by sex. So we see that we have the greater burden amongst those that were 10 to 14 and then 15 to 19 years of age. Now, we looked at positivity rate by class because we realized that that student was in year 10. So in year 10, we had a positivity rate of 54.7%, but in year 12, where we suspected that we had our primary case, we actually had a positivity rate of 70.8%, which further buttressed the fact that that might have been our positive case. Now, when we looked at the factors, there was no significant association with sex, but there was association with the class student was, and then, funny enough, we found out that day students were also more likely to be positive. Day or boarding, because they operate a system whereby some students do weekly boarding, and then they also have day students. But one thing we found out later is that several of them had decided to go back today after resuming for boarding. So we don't know whether that might have been because they were sick or something. So that could have been a confounder. Now, what did we do? Immediately, it was a joint team. We had members from the EOC, surveillance, IPC. We were all involved. And Honorable Commissioner was on our neck every step of the way. And the LGA team was also on ground there every day. So there was supervised isolation of confirmed cases and quarantine of close contacts. Then there was daily follow-up by the LGA DSNO. And there was restriction of movement during the active period of the outbreak. So day students reverted to virtual learning. In the school too, they also reverted to virtual learning with students learning while in their hostels. We ensured that there was provision of home-based care packs for all positive cases. And there were several interactions with parents and staff through Zoom platforms to provide updates and address their concerns. In conclusion, although the school had adequate hand washing stations, compliance with mask use was poor among both staff and students and was not enforced by staff. All positive cases and contacts successfully completed the supervised isolation and quarantine periods respectively. Our recommendations are that there is a need to establish linkages between schools and LGA authorities to facilitate prompt case investigation and testing, which is already ongoing. And we also notice that we need further training of staff, because we notice that most training the trainings that we've had are targeted at teachers, but we also need to target healthcare providers within school clinics, particularly for boarding schools. And we need to reinforce infection prevention and control measures, such as wearing of masks and social distancing. Sorry, I acknowledge the following. Thank you very much.
Okay. So Dr. Shiwabiola is here on behalf of Zendal. Carterbit. Yes. And we thank you for yesterday for helping us giving out some of the prizes. And it's, thank you. So probably on behalf of the other, just give me one.
Okay, good evening everyone. So maybe to stand on existing protocol, I just want to say a few words. I won't take too much of your time. Carter-Biggs Logistics Company is an organization that is focused on safely transporting medical products and clinical specimens between relevant stakeholders. Our involvement in the Lagos State Consortium has ensured the efficient dissemination of information through the use of technology and inventory management of medical supplies to ensure the rapid distribution of personnel, information, goods and services across the state. Carter-Biggs is honored to be a partner to the Lagos State government in the implementation of the emergency COVID-19 response. We are also very proud to be active participants this year in this pioneering conference, as we understand the importance of moving the dial forward in biosecurity containment in Lagos, Nigeria, and the continent at large. We would like to use this opportunity to recognize the leadership role of His Excellency, Mr. Governor Babajide Sanwo-Olu, in managing and flattening the curve in Lagos State. His able Deputy Incident Commander, Professor Akin Abayomi, and the entire health team of Lagos State. We pledge our continuous commitment to support Lagos State in ensuring that it remains at the forefront of biosecurity and medical advancements in this field, and that most importantly, it succeeds in its mandate to protect the lives of its citizens by containing and combating the spread of the infectious diseases. Finally, I would like to congratulate the organizers of this successful event as we look forward to attending subsequent ones. Thank you very much. Most of us, and I think when we came to come down, we all came together to move the state forward.
And we look forward to, well, we hope there are no more pandemics, but there are going to be several opportunities for PharmaSeq.
Oh, definitely. The truth is, as one of my learned colleagues said, why waste a good pandemic? Or why waste a good crisis? The truth is, we've gotten the opportunities to start afresh, and this time I pray, well, we're already on the right track to get everything right. Thank you very much.
A round of applause for him, Dr. Shil. In a way, he's going to close this conference by giving us or sharing us his thoughts and takeaways. That's how they put it. What do we take away from this conference? We've had 3 days. We've discussed everything along the spectrum: management, the science of it all, the organization, the collaboration, the standards we've tried to set, a whole raft of issues. But what do we take away? So I'd like to respectfully call the Honorable Commissioner, Professor Akin Abayomi, to come to the stand and give us his parting remarks and the takeaway. Thank you very much, sir.
These I can see are the diehards, the people that are left here this evening. Obviously, you're very committed to the cause. So, it's always a sad moment for me to close a GET conference. This is the 6th conference that we've organized. Because the meeting is usually very rich. It brings a lot of people together. It consolidates relationships. Unfortunately, this year, because we're in the middle of a pandemic, it has been an unusual conference. We've done a lot of it by virtual communication. And so it has lacked something. It has lacked that family of biosecurity experts that normally come together every year from all over West Africa, all over the continent, South Africa, Kenya, and from abroad. We normally have a full house of international biosecurity experts on the continent of Africa once a year for what's becoming the iconic biosecurity meeting of the continent. We've been to Ghana, we've been to Sierra Leone, we've been to Senegal. This is the 3rd meeting we're having in Nigeria. We had one in Lagos in 2016, and we had one in Abuja It was the meeting in Lagos that really consolidated the biosecurity roadmap for the state. And it was at that meeting that we really started to map out what we were going to do to make Lagos more resilient and less vulnerable to biosecurity threats such as COVID-19. And I think you will all agree that as a result of these meetings, there has been so much information transfer to different countries, to different health professionals that are interested in One Health and biosecurity. And as you can see, biosecurity is multifactorial. It brings climatologists together, it brings scientists together, it brings doctors, social scientists, civil society people, lawyers, security officers, psychiatrists, because that's just the nature of biosecurity. The nature of biosecurity is to ensure that everybody is safe in the environment, and there are legal ramifications, there are social consequences, there are security issues, there are health issues, and there's a whole environmental, climate, agriculture. So it's one of those meetings that's very interesting because it brings all kinds of different subject matter experts together to talk about how to ensure that we continue to protect our biosphere, and if there is an aberration in our biosphere, which is a bio-insecurity, that we correct it. So we've heard talks from different fields of expertise. It's been a very rich experience for you, I'm sure. At the end of a GET meeting, we normally prepare a declaration or a position. And I'm sure that at the end of the time, when the rapporteurs are able to put things together, we're going to come up with a position paper or a 2020 declaration, which will inform policymakers of what we feel they should focus on and prioritize for the coming year. So we're going to decide on the theme for 2021, and we are going to decide what side activities are going to happen. We didn't have much side activities today during this conference because of the size of the conference. It's probably the smallest face-to-face conference we've ever had because of COVID and isolation and travel restrictions. But I promise you that in 2021, when we've all recovered from COVID-19, the economies have returned to normal, people are able to travel again, that we're going to have a very big meeting to look back properly at how we manage COVID-19, the lessons learned, and what we're going to do moving forward to protect the continent of Africa from future biological threats. So on that note, I want to thank a whole host of people. First of all, I want to thank the chief host of this meeting, who is our governor, Mr. Babajide Sanwo-Olu, the incident commander of the Lagos State COVID-19 response. I'd like to thank the entire cabinet, several members of the cabinet graced the occasion. I'd like to thank the GET Consortium for working very hard to put this together. All your team members, you're getting larger and larger, your footprint is expanding. The fact that you've managed to have this conference right in the middle of a global pandemic is testimony to the hard work and the commitment and the resilience that your organization displays. I'd like to thank the Ministry of Health, Lagos State. So this is a partnership between GET and the Ministry of Health, Lagos State. Lagos State has always been embedded in this activity. Even sometimes when this conference moves out of Nigeria, you have a very large contingent of Lagosians following the conference to whichever city it goes to, making up almost a third of the experts that are attending the meetings. I'd like to thank our donors who have gracefully given of their time and their resources because of their interest to see that biosecurity strategies are developed. Thank you very much. I'd like to thank all of you that have come to participate, all our visitors from Guinea, from Rwanda, from other countries. I'd like to thank my colleagues, my fellow commissioners that have come from the other states to come and support this meeting. Many couldn't make it because of the circumstances in the country, but they've all sent their goodwill messages and hope that this will be a very successful meeting. Finally, I'd like to thank the youngest biosecurity expert in the world who's kept us entertained, and to the masters of ceremony. You've done a wonderful job. You know, it's not an easy thing to be a master of ceremony. I've tried it once or twice and I didn't do very well. Because you have to combine both a deep knowledge of the subject matter with charisma, with organizational skills. A conference is always fluid and dynamic, so things are always changing and happening, and you are always in a position to bend and duck with the changes. And from what I've seen, you've done a fantastic job. Your commentaries have been excellent. The way you've charmed the crowd, the members, I think both of you have just done a wonderful job, and we hope that we'll be able to attract you to the next meeting in 2021. I just want to say one final thank you to a representative of a good friend of mine, the National Security Advisor, Brigadier Babagana Monguno, who could not come, who were classmates in King's College. I saw him for the first time only a few weeks ago after a very long time. Of course, he's a very busy man and he couldn't come, but he sent a very able representative by the person of Dr. Damisa, who is seated here. Thank you very much once again for gracing this occasion. And I would like to remind you that Damisa in your language means leopard. Is that correct? So your other name is Dr. Amotekun. So on that note, to all the camera, this crew, all the support services, my team, the artists that came to display, my friends, my colleagues, the DJ, you play your music very loud, by the way, and all the support security, thank you very much. I appreciate your presence, and we'll see you again in 2021. Bye-bye.
It's about safety level 2 and level 3 laboratory that was established post-Ebola outbreak in 2014. We recognized that there was a gap in our diagnosis and response time to the Ebola virus outbreak in 2014. So Lagos State Biobank was the answer to that gap. So during this COVID-19 pandemic, Lagos State Biobank was responsible for the testing of samples in Lagos State, and sample collection, sample reception, sample testing, and then release of results on daily basis is by the Lagos State Biobank. And then secondly, along the way, we also make sure we validated the private laboratories that were involved in the testing for those who want to test compared to those who need to test based on case definition. So Lagos Biobank was involved in the training, on sample collection, reception, banking of those specimens, as well as data governance for those laboratories. And furthermore, Lagos State Biobank is supposed to respond to further outbreak because the staff of the personnel of the Biobank are trained on molecular diagnosis, current diagnostic techniques for any outbreak that may occur. Lagos State Biobank is the Lagos State answer to emerging and re-emerging infectious diseases when it comes to diagnosis. With diagnosis, there will be prompt treatment, so our response time will be much reduced than what it was before.
We've been having and scheduling this conference on the continent of Africa. It's been in many countries. It's been in Nigeria 3 times. It's been in Ghana, it's been in Sierra Leone, it's been in Senegal. The whole idea is that there's not enough information on what the concept of biosecurity is to Africa. COVID-19 is an example of a biosecurity threat, and it doesn't happen all the time. But when it happens, it causes severe problems. So like when we had the Ebola outbreak in 2014, it collapsed the economy of 3 countries and disturbed movement around the continent for quite a while. So when these events happen, these outbreaks or these pandemics, even though they happen periodically, but when they do happen, they have a potential to cause significant chaos, because we don't know much about the infective agent. It usually doesn't have a treatment. There's no vaccine, and there are quite a number of them. It's not just COVID. There's Ebola, there's other hemorrhagic fevers, there are other corona-like viruses, there's pandemic flu. So these kinds of infections, when they come suddenly. They take you by surprise. They make a lot of people sick. They can kill a large number of people, and they usually disrupt the environment. So we are trying to promote awareness both at government level and at medical level and in the population. What are the reasons why these things happen, and what do you need to do when they happen? Normally we're not trained for this kind of thing because it's not something that happens all the time. So under these circumstances, we usually have specially trained medical personnel. We use special facilities, we use special outfits, and we, carry out the business of managing something like COVID is not the normal practice of doctors, or other health personnel. So in preparing, we usually need to go through training. We need to build special facilities. We need to build special laboratories because these germs can't be kept in ordinary laboratories because they are dangerous. So in Lagos, we've been building since the Ebola. We've been building special facilities that you can manage these kinds of situations. And luckily, learning from Ebola, we've been building for about 3 years. My predecessor in health started. We were supporting him, and when I took over, we continued. Luckily, we had built enough capacity just in time for when COVID hit Lagos, which was why Lagos was able to offer some resistance to COVID-19 ahead of what other states had in preparation in the rest of Nigeria and other countries in Africa. So it's all about preparation. So these conferences, basically, they are to inform policymakers. They're to inform medical personnel that under the circumstances of a pandemic or an outbreak caused by what we call a pathogen of high consequence, in other words, when you have an outbreak caused by this kind of infection, it has high consequences, like lockdowns, loss of economy, civil unrest, sickness, lots of people getting sick, lots of people dying, so that's not the ordinary kind of situation. So that's why it's called pathogens of high consequence. It can collapse an economy. As you know now, the global economy has collapsed from COVID-19. So that's a consequence of the COVID-19 pandemic. So these meetings happen every year. We felt it was important that on the continent of Africa, that governments and policymakers are aware of this situation. You can have a period of several years and nothing happens. And then all of a sudden you get a situation. And if you've not spent time preparing, then you will be in a very difficult situation because you cannot prepare in a matter of weeks. It takes years to prepare. So if you hear that there's an outbreak all of a sudden and you haven't been spending your time preparing, you cannot